So, good evening, everyone. Welcome to yet another masterclass by none other than our own Dr. Abha Majumdar. And today we are going to learn all the tips and tricks about the most crucial step in IVF cycle, oocyte retrieval. So, let us hear from the pioneer itself. How did the journey go right from the day one when she did her first oocyte retrieval?
Oh, wow,
Over
that
to you, Dr. Abha, ma'am.
yeah, that would be very interesting, Tejashri, to ask. And the most challenging step in IVF practice, which actually determines work and efficiency of the lab in general, or the start of IVF, or it gives work to the embryologist in particular, and eventually dictates the success of the IVF program, is oocyte retrieval. It is so important that unless you don't retrieve oocytes, nothing can start. And as Tejashri thought, she just took me back into my memory lane where I first time saw oocyte retrieval in Mumbai at Dr. Sadhna Desai's private center, which was just a two-room center, where in one room she used to do oocyte retrieval. There was a small tiffin room where we would all sit and eat. And next to that, there was just a two-bed recovery. This was way back in 1991. She was Dr. Kocher's friend, sent me there. 2 days I stayed there and I saw only two cases. And she told me, it looks very easy, we go one into the other, one after the other follicle, we just go in and aspirate. It is not so easy when you will do it. And I realized later on that it's not so easy. Did we know that approximately 15% of the oocytes are missed, which means some thousands of children were actually missed being born? During aspiration, the temperature of the follicular fluid drops by almost 7.7 plus minus 1 degree centigrade. This is because it comes from the body and then it comes to the room temperature, which can never be 37 degree. Dissolved oxygen rises by 5 plus minus 2 volume percent. pH rises by 0.04 plus minus 0.01. And these changes could be detrimental to oocyte health, and effort should be made to minimize these. So a revisit to the oocyte aspiration procedure, we will consider anesthesia. It has become so standardized now. We used to be groping for sedatives, anesthetics, non-anesthesia, and we used to try to do aspiration in the beginning in all types of, circumstances. The equipment is now standardized. Preparation for ovum pickup is so standardized. The technique of ovum pickup is so standardized, and special situations may come with every OPU, which is inaccessible ovaries, endometriotic cyst during retrieval, whether we should flush or not, and complications. No procedure can be without complications. So we need to put one slide on complications. So we would start with anesthesia or analgesia for OPU. Is pain management necessary? One of the main aspects of ovum pickup is management of pain. These are young girls. For no fault of theirs, they have to undergo IVF, stimulation of the ovaries, which itself is painful for them. Right from day 6 or 7, they start having a lower abdomen, heaviness, pain, everything. On top of that, when we think that we are going to put a vaginal probe and put a needle through it, then pain management becomes very, very important. In all patients, if we try to do OPU, severe pain may occur in 3% of patients and 2% still experiencing pain 2 days later. It is therefore necessary to consider intraoperative analgesia and systemic post-operative analgesia, which should be prescribed to minimize intra and post-operative pain also. So you would have at least 2 patients in every 100 who would say, oh, I have so much pain on day 1, day 2, day 3. It takes time for this pain to settle down. Whichever technique is used, adherence to professional guidelines and presence of trained personnel and adequate monitoring and resuscitation facilities are of paramount. It is so important that you have everything, all facilities for any complication which happens due to the anesthetic or sedative which you are using. So we did a survey of clinics in UK long ago, and we found that 62% of the women preferred sedation. and 28 preferred general anesthesia. So this makes 90%. 3% said they want GA or sedation, whatever. 1.6% went for spinal anesthesia, and 5% still had it in para-cervical block with sedation. Now, 70% of the clinics were hospital-based with resuscitation facilities, and the rest were freestanding clinics. So it is so risky in freestanding clinics if they don't have resuscitation team right there. It might sometimes be very critical, and there have been case reports here and there where patients have been lost in this simple iatrogenic procedure. So, what type of sedation or anesthesia is given? This depends on cultural expectations. So, in India, we have very little cultural differences in this. And mostly people agree for general anesthesia. Then it also depends on the facility used for oocyte collection, whether you have resuscitation facilities or not. And if you don't have, maybe paracervical block after testing the anesthetic for any allergy to the patient, and also the medical financial rebate system where anesthesia anesthetist might become expensive. Well, general anesthesia is superior because no pain and significantly one collects more oocytes. No deleterious effect on patient and no difference in IVF outcome or egg quality. Anesthesia used for general anesthesia is generally called as TIVA, which is total intravenous anesthesia, which comprises these days of fentanyl plus midazolam and propofol with monitoring. So conscious sedation is midazolam alone, which is less effective and hence not preferred. Sedative alone, again, is unsuitable for OPU as they lack analgesic activity, and the procedure requires analgesia supplement either with local anesthesia like paracervical block or systemic analgesia, that is opioids. So if you want to give a sedative only, like midazolam, then it should be with opioids or it should be a paracervical block. Local and regional anesthesia, one word about it, though I have never used it. Yeah, paracervical block we've used in our earlier days, but not now for the last 20, 25 years. And there is risk of direct intravasation of injection due to close proximity to uterine artery and vein and the plexus, which is around the cervix. Rapid absorption of the local anesthetic from the parametrial tissue can be associated with sometimes toxic systemic effects. Intrathecal, spinal, extradural, we hardly think of giving it unless there is a real contraindication to general anesthesia, and maybe such patients may not be even allowed to carry a pregnancy. We only need to do egg pickup for them. And these definitely require an anesthetist, and it is time consuming. Side effects of hypotension, post-dural puncture, headache, and failure to obtain satisfactory block all could be the side effects as they happen in other surgeries. And delayed early morning voiding of urine in the immediate post-operative phase also is a side effect. What is our protocol? Midazolam 1 milligram IV followed by fentanyl 75 to 100 microgram intravenous. These are given as boluses. Then propofol 50 milligram bolus is followed by infusion of the same. Post-aspiration supplementation of oxygen 2 to 4 liter by mask till recovery, complete recovery of the patient for about 10 minutes. And we generally give injection Voveran 75 milligram in IV drip in the post-operative period for pain relief. Paramount importance is suitably trained anesthetist with a defined responsibility of monitoring the patient's safety and maintaining record is extremely important. So all about anesthesia, now you know what we use in our center and it works very well. What is the equipment? These are the 4 things which are required. The aspirator pump, which is on the top, the test tube warmer, which sits next to us also, and in the embryology lab, it is next to the window of ours. It could be next to the door also, from where the test tube from one warmer are passed to the other warmer. Then the needle and its system, and last is the ultrasound machine. So without ultrasound machine, we can do nothing, but everything is important. Without needle, we cannot do anything. Without the aspirator pump, we can't do anything except one thing, that is test tube warmer. But then we would have such a lot of drop in temperature that we would lose our egg quality. So first essentials step is, first check all your equipment, it's working, and look at the flow rate of your needle. Calibrate it. You can do it once and then the same quality of needle will generally have the same flow rate. What is the end point of oocyte pickup? Intact cumulus, which means that the oocyte is aspirated with the cumulus all around it. It's not a broken cumulus. So if the cumulus is intact, the oocyte is also intact. So if we can aspirate intact cumulus oophorous complex, it prevents oocyte damage. Then how do we calibrate the correct flow rate? That is the key to retrieving maximum oocytes in optimal condition. Flow rate through aspiration needle and tubing is dependent on inner diameter of the needle, total length of the system, and vacuum pressure, according to Pozzolu's law. And for optimal recovery of oocyte cumulus complex, flow rate of 20 to 25 ml per minute is recommended. What I normally used to do is, if I used a double lumen needle, then to bring the flow rate to 20-25 ml per minute, you may have to increase the pressure a little bit of the pedal pump, because these needles are longer and the connecting tubing is also longer. So for the longer diameter, the pressure has to be higher. So if you see a 16 gauge needle, the pressure should be only 60 to 80 millimeters of mercury. These are possibly, we don't use these. Then a 17 gauge needle, which we use, our cooks are all 17 gauge, whether they are double lumen or single lumen. 80 to 100 millimeter of mercury is the standard pressure. If it is a thinner needle, 20 gauge needle, then the pressure has to be even higher, which we again don't use. Cook's double lumen needle is 35 centimeters all in all, and the single lumen needle is 30 centimeter. The inner gauge is 17. The measurement of the inner gauge is 17. Suction pressure is generally up to 100 in single lumen, and for double lumen, we keep it 120 to have the same flow rate of 20 ml per minute. Viscosity of the fluid will affect the flow rate at a given pressure. So if you start aspirating an endometriotic cyst, you will find that the flow rate becomes very slow because the fluid is very viscous. So the more it is like water, it will flow with this rate of 20 to 25. Generally, follicular fluid is almost like water, so it flows or follows the same flow rate as water. Now, which needle will you select for your aspiration? So, this is when you set up a center, you look at the needle. Sharp needles with non-coring bevel reduces patient pain, discomfort, and also prevents risk of occlusion. I'll show you pictures and you will know what is a non-coring bevel, which doesn't core tissue which comes within it. So, and the pain is also much less and occlusion is also much less. So we use always sharp needles with non-coring bevel. They have to be stiff and smooth needles, which enable precise placement of the needle tip in the follicle. Select single or double lumen needle according to the follicular response. Whatever your practice is, we use both the needles and we select it according to the follicular response. Because again, we feel that if we do not aspirate oocytes, the whole IVF goes for wasted. So we have to give adequate number of eggs to our embryologist to start the ball rolling for IVF. Then all the tips now have a echogenic tip for enhanced visualization on ultrasound. Smooth internal lumens are very important, and therefore we use these needles only once, because once you use them, then there could be blood and other debris which could get collected on the inner surface. And if you use them again, they wouldn't have a smooth internal lumen. So even external surface has to be very smooth so that it just pierces through the tissue very easily. Both smooth lumen and the surface prevents damage to the cumulus oocyte complex and also easy insertion through the vaginal walls and ovarian stroma respectively. Tight fitting tubing is essential for watertight system with resistance to kink. So please, when you are checking, make sure when you've made all the connection, there's no kink in the system. It is a absolutely watertight system so that all the pressure which generates through the pump is reflected to the tip of the needle. All complications of oocyte pickup are iatrogenic and caused entirely by needles. Entirely by needles. I mean, whether you are able to pick up eggs or not, but whether you cause bleeding, you cause pain, you cause any complication, injury to any viscera is all by needles. So select your needle very carefully. These are coring needles. This is a double lumen one, and this is a single lumen, which has core means, and this is how the tip looks. So that if it pierces, then there's no tissue, it just pierces through the tissue till here, and then the other part enters. If it was round, then what would happen? It would go through the tissue, and that tissue could go into the needle. Now, this is a non-coring needle. The whole tip is like this. It may be very thin, but it could catch tissue into it. Whereas in this, there is very little possibility of having it blocked by tissue entering this needle. So characters are, one is sharpness, most important factor to reduce injury and bleeding by easy shearing of tissue. The vaginal wall and the ovarian stroma, which is absolutely close to the vaginal wall. Very rarely it is away, and that is a dangerous situation. Or if you have to go through the uterus, there you have a much higher risk of blocking your needle, even with the non-coring ones. So there is a band near the tip. This is a highly reflected surface to visualize as needle enters the ovary and once again as it is in the follicle. So you are able to see it. And the tip has to be bevel tip designed to increase ultrasound echo, so easy to identify the position of the tip into the follicle. So pre-aspiration precautions, calibration check for flow rate. It is always good to just check. Just take a needle, check that it is open. We have had new needles which were found blocked, and we send them back to the supplier and they changed it. So first thing is you pick up a needle, just check it, take a little media in a tube about 20 to 25 ml and put a stopwatch and see what pressure you pull out 20 ml of media, the medium and the needle to be worn to prevent thermal shock. So needles are made of metal. They tend to get cold very easily. So we put them in a hot case, which is at 37 degree with the whole cover of it. And even the medium is kept in the incubator at a temperature where it is at 37 degrees. So they just take it out from there, the medium, and the needle out uh, from the warmer, and then they give it to us. So there's very little time when the needle could become cold, especially if the air conditioner is on. Sterile needle is inspected for tip sharpness and kinking of tubing. So whenever you are opening it, you know it is sterile, you've checked the flow rate, and then when you make connections, just see that it is all watertight and there's no kinking of the tubing. Aspiration system tested for patency before use by placing the tip in a spare test tube containing 5 ml of culture media. In fact, you can do it by even 20-25 ml of culture media. But even if you only want to test patency and this is the needle which you've been using for long and you know the flow rate, then you just use 5 ml of culture media. Aspirates are collected in the test tube warmer at body temperature. So these tubes are inside the warmer and the connection goes on the cap on the tube, which is in the warmer. So all the fluid is collected in the warmer, which we set 1 degree higher than body temperature, that is at 38.5 or 39, because room air keeps cooling everything very fast. So as soon as the fluid goes into that the connection is separated, the cork is put into another tube with the whole system which connects the needle, and that tube is closed and handed over to the warmer in the embryology lab, which takes hardly 5 seconds. This prevents thermal damage to oocytes, which can lead to spindle disaggregation if there is a lot. Then needle insertion. You can see in the first diagram, which is a picture where you've taken the ultrasound probe into the vaginal fornix, and from here you will advance the ovary, you will advance the needle from here to the ovary. Now, here you can see this is the needle tip in a follicle, and this, after it is aspirated, you will bring it to this follicle, aspirate. Don't release the pump every time. Keep holding on the pump and go on doing the follicles which are in vision directly. And one time you will have aspirated all these and you will have nothing on vision. You just move the ovary a little and you will get this little follicle and this one also. Rarely you have to take out the needle. If you cannot, after rotating, you do not get to see more follicles. I had a very beautiful video, but I think it's not playing today. So introduce the vaginal transducer into the vaginal fornix and visualize both ovaries first and see which ovary is easily accessible. Are both accessible? And take the biggest diameter in front. Try to keep rolling your transducer so that a nice big diameter comes in front and you can penetrate 3-4 follicles in one go. Identify follicle to be aspirated and centralize the ovary to the screen. Keep ovary close to the transducer with firm constant pressure on the probe. So if you see, this is the fornix here and the probe is almost pushing the fornix to the ovary here. So you have to really give pressure inside to lift up the vaginal fornix towards the ovary. Ovary will stay where it is. It is the transducer which will go close to it. Needle advance through the vaginal wall. In one push, you take it within the vaginal wall and into the ovarian stroma. Once the ovary gets caught into it and the follicle is in front, then you have sort of hooked the ovary and you can go from one to the other follicle, even if it is a mobile ovary. Keep the needle tip always well visualized and within the ovary. Rotating reflects the bevel. So if sometimes you don't see it very well, then just rotate it, either clockwise or anti-clockwise. Avoid bending the needle while it is moved. Ensure the tubing doesn't get kinked during use. Aspiration of follicle. Start the pump as soon as you enter the follicle and do not deactivate till the needle is withdrawn completely, as this may result in loss of oocytes. So from one to the other to the third to the fourth. And when you are withdrawing the needle, keep the pump on so that all the fluid which is in the needle also collects in the tube and that could contain your oocytes. So just leave the pump once you've withdrawn the needle from the patient's vagina. In large follicles, in larger follicles, you might have to do a gentle curette, which means just rotate the needle tip with the bevel on one side and then the bevel on the other side. And sometimes it just tears away the cumulus oophorus complex from the place where it is attached to the ovarian follicle. Important to see that follicular fluid doesn't come to the top of the tube to prevent it from going into the wrong line. So always be careful. If your follicle is so big that you feel it's become cystic, then only there's a possibility that this fluid may fill up the tube and go into the wrong line. So please, one assistant should be standing there who's changing the tubes to see. And if any cyst is so big, then about 1 centimeter, 2 centimeter before it reaches the top, one should stop, disconnect it to another tube. When moving to the next follicle, withdraw the needle and then advance to the next follicle without releasing the pressure. Gently rotate the needle to ensure the fluid is sucked completely. If you feel that the fluid is sort of left behind the needle, just rotate the needle and the bevel will go to that side and it will be able to suck. Sometimes what happens, the follicular wall starts collapsing and it obstructs the bevel. So you have to, the same as when you do suction in a laparotomy, if something comes and obstructs the suction, you have to move the suction tip so that that obstructed organ, whether it is mesentery, omentum, intestine, anything, you just have to release that organ by moving the pump. Here also, you just rotate the bevel to have it away. Here was the video, which is not really working. So all about the needle, about the aspiration pump, ultrasound, you all know that you have to have the vaginal probe indicator on with a biopsy needle. So, what are special situations which you would encounter? So, you know all about how to aspirate, you know how to choose your needle, you know that, how do you calibrate and how do you use the suction pump to optimize the flow rate, and you don't take your foot off, you don't use it like a brake and a car accelerator. Just keep accelerating, and if you have to go to another follicle, if you are going straight, go in. If you want to change the whole direction, pull out the needle and then change the direction. Now, what are special situations? Inaccessible ovaries. In 2 out of 100 cases, we do find inaccessible ovaries, common with pelvic surgeries, fibroids, adhesions, endometriosis, and some congenital anomalies. The congenital anomaly where you have most difficult access to ovary is the syndrome, MKRH syndrome, where the ovaries are probably lying near the abdominal wall outside the pelvis. Otherwise, even with fibroids and endometriosis, like you see in your surgeries, that both the ovaries are stuck to the POD. Same thing happens here also, that they are stuck there, and there's no way to go from the side of the uterus to reach the ovary, even though it is a stimulated ovary, and you may have to pierce either the cervix or the wall of the uterus to reach the ovary. So how do you manage? First is, please always empty the bladder if you find it is slightly full. Vaginal scan probe manipulation with abdominal pressure. A lot of times you just take the vaginal probe and you manipulate it, and sometimes giving abdominal pressure on one side or even the contralateral side brings the ovary suddenly closer to your probe. Rarely you may have to use tenaculum for cervical traction. Transmyometrial oocyte retrieval is what we do, that we have to pass the needle from the myometrium and get the oocytes. And we've done it for maybe one ovary sometimes for both ovaries. So this happens mainly in post-operative endometriosis. And trans-abdominal oocyte retrieval, we've only done in MKRH syndrome, where there was no way from the vaginal side that we could reach these ovaries. And laparoscopic retrieval is last, but was the first retrieval of Louis Brown. Having said that, if there is a cyst, now so many women with endometriosis opt for IVF directly or go for IVF after having had a surgery. So a huge number of patients who enter our IVF program have underlying endometriosis. So what are the management options? That you aspirate all follicles that may be reached without damaging or entering the endometrioma. This should be our first aim. So we always look at endometrioma which is distal to the vaginal wall and the follicles are proximal, or they are on a side where you can just leave the endometrioma and go to that side of the ovarian tissue and go on aspirating the follicles. If there are follicles distal to the endometrioma, earlier we never used to cross the endometrioma. Even now we want to always avoid going through the endometrioma, but in rare instances where very little follicles are there, one might have to, pierce through endometrioma and reach the follicle. However, we have to be very cautious in the post-operative phase that she doesn't have peritonism and leakage from the endometrioma. Aspirate all follicles in low responders with the risk of puncture of endometrioma. Like I told you, that you may have to puncture because she's a low responder and all you need is 3 or 4 or 5 eggs to be able to give her one good blastocyst. Concomitant antibiotics are very advisable, and you may also use injectable if you feel, and a gram-negative coverage if you feel that you've really punctured the endometrioma, that also not once, maybe multiple times, and hence there is a lot of risk that there could be peritoneal leakage of the endometrioma. And sometimes postpone IVF before starting stimulation in the next cycle and perform cystectomy if follicles are present behind the cyst with fixed ovary. Suppose you find the ovary is very fixed, it is behind the uterus, and the whole of endometrioma is towards your needle. Then you will always have to pierce through the uterine muscle, cross the endometrioma, and then reach the follicles. These are generally low responders, so you can probably cancel the aspiration and do a surgery just to, make the ovary more manageably accessible, and go ahead with OCR. So another question is, should we flush or not flush? We use double lumen retrieval needles, which allow for simultaneous or intermittent flushing and aspiration of ovarian follicles. And the follicle flushing aims to increase the number of oocytes retrieved. And ultimately, we all know now that the pregnancy rates are dependent on number of oocytes retrieved. The whole Poseidon criteria depends on number of oocytes retrieved. 50% ART specialists perform follicle flushing on a routine basis. Follicle flushing may have its ultimate utility among poor or low responding patients, which are, this is 10% of ART population, I would say 40%. Controversies on flushing are there. There are a lot of people who say flushing adds no benefit. Other people say flushing is good and there is improvement. Then they say that it increases procedural time plus minus 15 minutes. So we have a lot of evidence saying that flushing may not help, but then we also have evidence saying that flushing does improve the oocyte recovery rate. What are the complications? The problem is very few studies are there on complication of oocyte retrieval because this is such an iatrogenic procedure which would implicate the person who is aspirating. And therefore, very few are reported, and especially those where the patient has recovered. Where we lost the patient, they are not at all reported. So all complications are retrospectively seen. And majority of publications are case reports. Many centers do not report complication, particularly the minor ones. So what are the complications? Well, if you see, it starts with pain, 3 in 100, hemorrhage, 3 in 100, infection, 1 to 5 in 1,000. Severe hemorrhage is about 1 in 1,000 again, less than 1 in 1,000. Damaged, severe hemorrhage, we mean to say, where you will have to give additional treatment. Damage to pelvic structures in less than 1 in 1,000, adnexal torsion in less than 1 in 1,000, and anesthesia complications are very rare. So the highest is 3 in 100, otherwise healthy patients undergoing OCR become ill patients. And what happens? Bleeding is the first thing. What do I need to know? I need to know when did the bleeding start? And bleeding from where? So we have made a protocol after 1 or 2 cases which came back to the hospital in the evening saying that they were feeling dizzy and bad, and then we did ultrasound and found blood in the POD. We have a checklist before the patient goes home, which is 2 hours after egg pickup. The patient goes through ultrasound again to see how much fluid is there in the POD, her pulse, BP, everything is checked, and then she's sent home with a list of things that if she feels dizzy or if she feels that her abdomen is bloating, she needs to come back to the hospital. Then once you determine when the patient is there, so it is generally after the procedure, and rarely after 12 hours you will find any bleeding. So whatever will happen within 12 hours. So first thing, when you see that there's bleeding, you'll see where is the bleeding from. One is immediately after oocyte pickup, you find that there is a lot of bleeding. So look, it could be the vaginal wall, it could be ovary, it could be sometimes a corpus luteum. This is a later bleeding. Corpus luteum rupture is a much later bleeding. Right now, it is vaginal wall. So it is either shearing of the vaginal wall or where we punctured the ovary. Ovary was very vascular and hence it's bleeding. Ovarian bleeding is difficult to control because it is intra-abdominal, whereas vaginal bleeding is the easiest to control because first is you apply pressure. If it doesn't work, you can apply a stitch. What do we do? So then you have to see the next thing is how much of bleeding is there. So on ultrasound, you measure the amount of fluid which is there, and not more than 200 ml of free fluid by ultrasound. It should be less than 200 ml. If it is more and hemodynamically patient starts becoming unstable, it is very important that we keep a monitor, arrange blood for her, And what do? We keep observing her. We don't like to touch a patient who's hyperstimulated. In very rare instances, one may have to do a laparoscopy or laparotomy, and we pray that the bleeding should stop. So on laparoscopy also, you can't touch these ovaries because they are so hyperemic that they may bleed from multiple sides. A stitch doesn't work over there. So we just give blood, wait, and see that she stops bleeding. That is how it happens. And we are doing IVF since 1990. So it is over 35 years. Maybe 2 or 3 instances where the patient came back within 12 hours that hemodynamically unstable, but we never had to put in a scope or do a laparotomy for anyone. 1 or 2 bottles of blood had to be given to, I remember, one of my patient, but then everything sort of recovered. Then severe bleeding may also occur due to direct damage to the uterus. You've punctured the uterus. Now, if you make a big hole in the uterus, which is vascular, it'll keep bleeding. The bladder can be injured, the colon, the pelvic blood vessels, which are misinterpreted as follicles. This is the biggest thing, that when you are doing follicular aspiration, please rotate your probe to see whether you are within the ovarian margin or you've gone out of that, looking at a round structure. Because if you turn your probe, you'll find it's a linear structure, which was appearing round when you were at the transverse diameter. So please do not get into a blood vessel thinking that it's a follicle. Then if there are medical problems influencing coagulation, we don't know. These are young girls. We don't know if they have deficiency of factor 9, essential thrombocythemia, or prophylactic anticoagulant therapy. Now we know that if anyone is on prophylactic anticoagulant therapy, we have to stop it at least 24 hours earlier. And one case has been reported in 1991 of ovarian necrotizing vasculitis, where the main ovarian vessel was punctured and it led to necrotizing vasculitis, some infection, and the whole ovary underwent necrosis. Number 2 is infection. Incidence of infection, different people have given different incidences of infection. These are more in the earlier days. What are the pathways? Direct inoculation of vaginal microorganism by puncture of vagina by the needle, reactivation of latent or chronic infection, PID, puncture of hydrosalpinx or pyosalpinx, contamination from trauma to the bowel. You've made a hole in the bowel and there is dermoid cyst inadvertently aspirated due to poor resolution of ultrasound machine. Consider a dermoid reason not to accept a donor. Please remember, a dermoid cyst, as if by mistake also you go into a dermoid cyst, it is a very big source of infection, and do not accept a donor who has even a small dermoid cyst. How to prevent pelvic infection following oocyte retrieval? Well, minimize needle punctures. Try to take out as many follicles with one needle puncture. Prophylactic antibiotics, we always give antibiotic on the table, 1 dose. Disinfection and thorough washing of the vagina. And we do betadine vaginal preparation for high-risk patients, those who have endometriosis. And we always treat our patients' vaginal infections prior to taking them for IVF if they have any. So PS examination is a must in our patients. All patients who are taken for IVF on their first visit, they have a pap smear and they have a per speculum examination to rule out any infection. And if it is there, it is totally eradicated before even we start stimulation. Injury to the bowel ureter, is there a possibility? It is more theoretical than actual to the bowel, because the bowel keeps on moving. And if it is a mobile bowel, then it's difficult for the needle to puncture it fully. And a small needle puncture may resolve spontaneously without being diagnosed. Given the anatomical position, immediately anterolateral to the upper fornix of the vagina, ureteral injuries are very rare. You know where they are. So it's very rare that you go right into that area and you push your needle into the ureter. And there have been 2 case reports of perforated appendicitis with puncture holes in the appendix. That appendix must be lying in the pelvis and the puncture went into the appendix and perforated appendicitis. So very rare complications are vertebral osteomyelitis after oocyte retrieval, neurological signs in left leg, and adnexal torsion. Torsion we still see these days. So it is very important to report cases so that other people learn from our mistakes. So one caution is that if the ovary is high, please bring the high ovary down with a tenaculum and abdominal pressure. Don't chase it. So you push your probe as far as possible and try to see that the vaginal wall is next to the ovary. Either you pull the ovary down, you pull the cervix down with a tenaculum to bring the uterus and ovary down, or use abdominal pressure to bring the ovary down. Do not chase it. If you chase it and the ovary and the vaginal wall has a distance and there is bowel or mesentery, anything over there, you will go across it. Fortunately, oocyte retrieval is a safely practiced procedure, and we are lucky to not have seen or experienced complications of this magnitude. What I have seen is pain. I have seen bleeding, but bleeding which stopped on its own. And torsion, yes, we've seen maybe in a year we do get one case of torsion of hyperstimulation, but generally these are referred to us. And because we have very limited doses where we stimulate our ovaries, maybe in 2 cases in a year, we have our ovaries really hyperstimulated where we get more than 25 oocytes recovered. Thank you very much.
Thank you, Abha ma'am. As usual, I'm sure on behalf of all the audience that have joined today, we all have learned a lot despite thinking that oocyte retrieval is a everyday procedure. I'm sure everyone from senior to junior has learned today from Abha ma'am. Thank you so much, ma'am. Shall we take the questions, ma'am, now?
Yeah, sure.
So we have 15 minutes left, ma'am. The first question is by Dr. Neeraj Jindal. In fact, there are 3 or 4 questions in the message, and they want to know whether the pressure of single lumen needle is 100 to 110. I think that ma'am has
Yeah,
answered.
that's
What should be the criteria for trigger? If 3 follicles are 18 and rest are 14-15
whatever your trigger is. You've decided to use a HCG trigger, means Ovitril these days, or a GnRH agonist. Everything depends on what your practice is. You can give any trigger you want, dual trigger, or you can use one of the two, whatever. If you have only 3 follicles are 18 and rest are 14-15, what is the E2? How many other rest of follicles? Are there 20 more follicles, or are they just 2 or 3 follicles? And that will depend your trigger, right? If
Yeah.
you have rest are 14-15, how many are rest? Rest could be 10-15 also each ovary. So then you use a agonist trigger. But if you have 3 big follicles and 2, 3, 14, 15 millimeter follicles, then you can use a dual trigger or you can use HCG. From where do we start picking up the follicle? Well, you keep moving your probe to come to a situation where the ovary is lying in front, and you see the largest diameter of the ovary in front of you, and the follicles appear large and big, one piled over the other. That is where you start your picking up the follicles. What about use of Doppler? Well, I don't know. I've never used it. Does PCOS affect oocyte quality? No, not as far as I know. Yes, sometimes it may. What can we do if ovary is behind the uterus other than lifting up abdomen or pressing it? You can do nothing. If the ovary is stuck
Ma'am, like
behind
you
the
said that,
uterus,
yeah, we can pull it with the tenaculum, pull the cervix so that it comes a little down.
yeah,
And
you
sometimes
can
we
put
might have
the
to go through the uterus.
yes, correct. So you know the answer what Tejashree is told, that you can use a tenaculum along with the vaginal probe on that in that forceps. With the tenaculum, you pull the cervix to the other side so that maybe the ovary comes more towards your probe, and go through the
Yeah,
uterus if you have no.
option. Yeah. Ma'am, Dr. Basima is asking whether we should release the pump when the tube is being changed.
You tell us what is the practice, Tejashree?
Not
We
really,
don't
ma'am. We
release
don't
the
have to.
pump.
We just go on doing the suction and sister keeps on changing
Yeah,
once the
even
tube.
if you release the pump, the pressure is
Yeah,
released when you
pressure
are
is
changing the tube, no? The moment
yes
you take off the cork, you have removed the watertight system. To whether you release the pump or not,
or not.
pressure
The
is
pressure is
gone.
going to change.
Yeah. So you can continue to press the
Do
pump.
the suction. Yeah. Dr. Shubhi is asking, ma'am, needle to be warm to prevent thermal shock. Does that mean flushing with warmed media?
If you are using a double lumen, then we only try to block the space. Our needles are kept in a warm, what do we call that? That warm incubator जो hot
Warmer,
का रहता है वहाँ से निकाल के देते हैं. तो our needles are generally at body temperature 37 degree.
30 seconds.
Yeah.
Will you advise routine antibiotics?
We do give one dose there, and in endometriotic patients, especially if we prick the endometrioma, we continue for 3 or 5 days also. And a lot of times when I think that no, this was a bad endometrioma, then we can even give injectable antibiotics, right? That is our
Right, ma'am.
practice. Hmm?
Yes, ma'am.
Hmm.
Ma'am, do you advise use of double lumen needles?
You tell us, you are doing
Uh,
aspirations.
yes, ma'am. We do use it for patients with either low reserve or where we are expecting a lesser number of follicles, and we do use double lumen in that case with
Yeah,
flushing of
because
the
you know,
follicle.
the first thing is if you do not retrieve oocytes, you have three follicles. You've used a single lumen and they say no eggs retrieved. Now, what do you do? So we go on washing and always we are able to retrieve out of three follicles, one, two, or even three.
Yeah, we have consultants who sometimes don't prefer to use, but we have seen that
Yes.
with double lumen we do get more follicles
Yeah, more oocytes.
compared to
Yeah. Hmm.
more oocytes, sorry, more oocytes compared to single
What
lumen.
do you do if
What
patient is having hematuria? Very
hematuria?
important question, Neeraj. This is when your bladder is punctured. So please be very aware of emptying the bladder if you find a full bladder, because a lot of times when the bladder is full, it lies on the sides, and sometimes when you're manipulating your needle and the ovary is sort of running out of your needle, you could go through the wall of the bladder and you would have hematuria in that case. Just wait and watch, and this hematuria should settle down unless you've really gone through the bladder.
Ma'am, can we use Tranexa in that case?
Yeah, you
Because
can use
we
anything, I
can
think,
get
whatever can
injectable
stop
Tranexa to
bleeding.
stop. Yeah.
Yeah. You can give
Assessment
a
of 200
1
ml.
gram
Yeah.
of Tranixa injection.
Tranexa intravenous. Yeah.
Hmm.
Assessment of 200 cc in scan post OPU. Uh, is it
You have
absent?
a way you can measure the volume. I think all ultrasonologists know to measure the volume. And two
Mhm.
is, if for hematuria, always catheterize your patient and leave the catheter in to see whether it is increasing, decreasing, and ultrasound will also might be able to see a hematoma if it is over the bladder.
Right, ma'am. And again, the same thing. Can we give Tranexa if there is excessive bleeding? Will it help?
Then sometimes we are not able to approximate the ovary with the probe and something is coming in between. Please do not advance your needle till you are sure that there's no bowel which is coming in between your ovary and probe.
Right, ma'am. Ma'am, how to do abdominal oocyte pickup?
This is again a very tricky situation where we use the abdominal probe and you locate the ovary, and I have done it. So you have to put the antiseptic on the abdomen, use a sterile transparent glove for the probe and put jelly over it. And then this has to be put over lot of, we have to put lot of antiseptic on the abdomen because they need a wet surface to be able to see the follicles, and one person will help with that, and there is no biopsy needle in the abdominal probe, so you have to sort of mm, look at the ovary, and right
Maneuver.
from the center of the probe you go in, and a lot of times you can reach it very easily. Is there a biopsy probe, Tejashri? I'm forgetting. Is Bhavani there? Do we
Bhavani is
have a
not has
biopsy
not joined today.
indicator in the abdominal probe? How did I go in that day?
Ma'am, generally there is a biopsy indicator in abdominal probe as well
Yeah.
because these people do amniocentesis and all. They do have
Not only
biopsy
amniocentesis,
multiple
they do a lot of biopsies, no? So there is a
biopsies
middle of the
transabdominal.
biopsy in the
Yeah,
abdominal
there
probe
is.
also.
Yes.
So when you see that line is going through a follicle, on that line, you would go inside and do egg pickup.
Is there a role of
General
general
anesthesia, we
anesthesia
always
for
give. Tiva is general anesthesia.
And ma'am, sometimes we do need insertion of tube also in obese patients, especially where there is a
Yeah.
tongue fall and there is risk
Yes,
of
yes. Please have a good anesthetist who have all resuscitation measures. It is very important to have all resuscitation measures over there in the IVF lab.
yeah, because
Pediatric
obese
injury,
patients can
very,
have
very
tongue.
theoretical possibility. Betadine, we do use for our endometriosis patients, especially after the pickup, but even before I've used it. It doesn't, you can use lot of betadine, wash it with saline, and then go in with your needle.
चेतना से पूछ लो कंसल्टेशन के लिए फॉलोअप के लिए आना था ना नहीं तो फिर बोलो मैम 3 days बाद फिर आपकी फुल कंसल्टेशन
Team, can we just mute the participants?
Yeah,
Any
all the
preference?
insertions are between, I would say there is no clock that can follow. When you insert the probe into the vaginal fornix, sometimes you have to go posterior, sometimes you have to come anterior, depending on what is the position of the ovary and where do you see the follicles best. So there is no 3 o'clock or 9 o'clock position which you could take or you could avoid. You just see the ovary. Just forget your 3 o'clock, 9 o'clock position because you are not going into the cervix or the cervical vessels or the uterine vessels. The ovary is much further there. So please locate the ovary, make sure the vaginal wall, your probe, is absolutely in contact with the ovarian margin. Go
Any
medial or
recommendations on
lateral
going
first is
medial?
again depending on where your ovary is situated and where do you have the largest follicles. This only comes with experience. Don't go lateral or medial thinking that, this should be the first thing. The approach should be direct towards the follicle. Ma'am, can we have a video of abdominal OPU procedure? Next time when we do it, we will make a video. And I will post
Surely, and
it
then
on
let
the
me
forum.
find out if any of our consultants has it. If we have
Hmm.
it, I'll surely try and post. We have 4-5 more minutes to go. If anybody wants to unmute and ask a question.
In mobile ovaries, with
Ovaries,
ovarian reserve, there is a lot of risk in mobile ovaries, So we give abdominal pressure, you try to hook the ovary. What I do is I just thrust the needle like as if you are throwing an arrow at someone so that it just gets into the ovary. But please don't do it unless you are 100% sure the ovary is right opposite the vaginal wall so that you don't have injury to the vessel. Laterally, you don't go so lateral. I have sometimes feared that I have hit the posterior pelvic wall in puncturing or going behind the ovary. But very thankfully, nothing happened which was wrong. So don't chase the ovary ever.
Ma'am, what do you
Ma'am,
mean by
according
not chasing the ovary? I don't understand. What do you really mean by don't chase the
Okay.
ovary?
All right, I'll tell you. You've gone into the vaginal fornix and you find the ovaries a little further away.
Mm-hmm.
Now you are trying to go into the abdomen and trying to reach a follicle in the ovary. Unless the ovary is right opposite the vagina, and the moment you pierce the vaginal wall, your needle should enter the ovary. That is the safest position. But if after piercing the vaginal wall, your needle is sort of searching to get into the ovarian follicle in the abdomen, that's a very dangerous situation. The ovary
Okay,
is a little
got it.
further, that is chasing the ovary.
Got it. Got it.
You
Ma'am,
push
but
your probe
pressure,
as much as possible. Don't be afraid. You won't tear the vagina. Just push it enough. If the ovary is still far, then ask someone to give a little abdominal pressure. You'll see the ovary will come and rest over the vaginal fornix. That is
does abdominal pressure make the mobile ovary more prone to torsion?
no, absolutely no, not torsion. But yes, abdominal pressure sometimes doesn't work very well. I
Mhm.
have seen that a lot of times sisters come to help me that, oh, the ovary is running away, and we'll give a little pressure. But you do not advance the needle if the ovary is running away. Stay there, try to manipulate everything, try to bring the ovary, प्यार से ले आओ उसको नीचे, कभी same side, कभी opposite side में pressure देके, कभी एक certain angle.
Mhm.
The whole team will have to help you there, where to give the pressure, where your ovary comes and lies very close to the vaginal fornix, where your probe is. Probe तो तुमको पता चल जाएगा ना, on ultrasound you can see where your
Yeah.
probe.
Thank
And
you
when
so
you
much.
start advancing your needle, you can see in the line where it is advancing. So if you straight away from vaginal wall go into the ovary, that is the safest situation. But if the ovary is away and you think that needle अंदर डाल दिया, अब हम ovary तक पहुंचेंगे, वहां gut बीच में आ सकती है.
Ma'am, in rare scenarios, if we are not able to push the ovary with abdominal pressure, with tenaculum, then should we leave the, and
Yes.
it's a hyper responder patient, then what is the way out?
हाइपर रिस्पॉन्डर में ऐसा होता नहीं है, इतनी बड़ी हो जाती हैं ओवरीज, विद सो मेनी फॉलिकल्स देयर दैट दे ऑलवेज कम एंड टच द फॉनिक्स. बहुत रेयर होगा कि हाइपर रिस्पॉन्डर ऐसा
But
हो.
sometimes, like ovary moved, once the ovary becomes bulky, it moves to the POD. And
हाँ, तो वहां से तो तुम आराम से निकाल लोगे बेटे, उसमें कभी
Hmm.
प्रॉब्लम नहीं होगी. इफ द ओवरी इज बल्की एंड इट मूव्स टू द पीओडी, तुम थोड़ा सा पोस्टीरियर फॉर्निक्स ऑफ द वजाइना से चले जाओगे.
And
उसमें
if we have to go through the uterus, what are the precautions we need to?
you have to make sure that your needle doesn't get blocked, because mine got blocked multiple times. And when you are right into the follicle and nothing is coming out, then you suspect that, even with a non-core needle, tissue has gone into it, the uterine
Tissue.
Also, when
And
we go through the uterine wall, it is very restricted mobility of the needle. We can't move it in various axes. That's one
Yeah.
challenge when we go through the uterus. So we should
So
be
you have to
entering at a
be
point
sure
where we
that,
can aspirate maximum number in the same line. So
yes,
we'll have to keep
बिल्कुल
that axis
सही
in
ऐसी
such a way
जगह में
that
ओवरी और प्रोब का वो रखो कि
होना
आप
चाहिए where we can
जाए टिश्यू
aspirate
से.
the maximum number.
Yeah. And if you can aspirate one, you'll be able to aspirate all, because that means the needle is not got blocked. But if you're right in the middle of the follicle and you're not being able to aspirate it, 100% your needle has got blocked. You'll have to take out, check, maybe change the needle or increase the pressure to 300, 400 outside the body with a little media in another tube, and see when that pressure can sort of flush out what has gone into the needle. If it doesn't flush out, then you will have to change. Today only I did this for a patient with very low ovarian reserve, and I could get 5 oocytes for her. In the first IVF, I'd got 4. So I had to change the needle after we got 4 oocytes, because my needle got blocked. And that is because she is a case of endometriosis. She's a case, but I did not go through the uterus also. It was only ovarian stroma which blocked her needle. And hence we had to change it. And how did we know it is blocked? We took some media in another test tube. We aspirated. The nurse increased the aspiration pressure to 500 also, but we couldn't get rid of the blockage. So we changed the needle and we got 1 more egg in return. This was a double lumen needle. Now in double lumen, the media goes from the outer part of the bevel center. So when you wash it, the media is going from the area all around the central channel from where the egg is aspirated. So if that central channel gets blocked, even by washing, you cannot get rid of the blockage.
so sometimes, ma'am,
We only give single flush most of the time. Dr. Rachita
Single
is asking
flush,
how many
yeah.
flushes are recommended in poor responders. So we just
No,
flush it once.
we all do
But we
single
can
flush.
give it. Yeah. Sometimes if we feel that it was inadequate and enough media did not enter the follicle, then we do it twice also sometimes. But generally we
Normally,
do it
I do it only once, mostly.
once.
And earlier days, we used to do double, triple. Dr. Kochar used to keep sitting
Yeah,
and
yes.
until the embryologist would say, "Ha, egg mila."
I have
But
seen
those
her.
were very early days in the 1990s.
and do you release the suction pressure while flushing, ma'am?
No,
You don't.
no,
Okay.
No.
no. सक्शन प्रेशर को हम लोग तभी रिलीज करते हैं जब हम नीडल को विड्रॉ करते हैं. As long as it is in the ovary, we go from one follicle to the other. We do flushing, because the needle has to be in the follicle when you're pushing in flushing media, and you'll see that a little bit of turbulence is happening in that follicle,
Right.
and white echoes are coming up because maybe a little air also gets mixed, maybe. And then when you pull it out, it all comes out very beautifully.
Dipti Loda, Dr. Dipti was about to say something. I think that's the last question we can take for today.
What is it?
Dr. Dipti?
How much media do we use, ma'am, to flush it with the double human needle?
Generally, it's
We
1
have
ml
the
per
whole
follicle.
syringe full of media. If we have lot of follicles, one syringe, two syringe also may be needed, but we don't use a double lumen when there are a lot of follicles. We only use it when we
Yeah.
have
So generally, ma'am, we put about a ml per follicle.
Okay.
maybe 1 ml और उतना ही निकलता है, कभी कभी 1.5 ml भी आ
हाँ,
जाए तो
yeah.
it's okay.
Thank you.
So that much of media should be enough. So if you take a 10 ml syringe full of media, it should do for your whole aspiration. But rarely we get very impatient. We inject more than 1 ml and then the media finishes and we have 1 or 2 more follicles left, which we want to flush because we want to have as many oocytes as possible.
So thank you so much, Dr. Abha ma'am, once again for this wonderful lecture today. The discussion was really
Yeah,
insightful.
it was so
Thank you,
basic,
everyone.
but I think someone had requested for this lecture last time on the Masterclass
Yes.
WhatsApp group. That is why I thought that let me take this
And
lecture.
I think for all of us to learn is your enthusiasm, as always. Thank you so much, ma'am. Looking forward to your next class.
Yeah, thank
Thank
you.
you
Thank
and
you
good
for
night.
all
Good
being
night,
there.
everyone. Thank you for
And
joining.
I thank all those who have asked questions because that makes me feel that yes, this lecture was worth it. If there are no questions, maybe I'll stop taking the lectures also. Thank you, Vishal, for always
Thank
being there for this platform, giving us this platform free of cost that we can all learn and teach together.
you, ma'am.
Okay,
Thank you, ma'am.
thank you.
Support team end the meeting.
Yes, sure, sir.